Chest pain is a symptom that often raises alarm as it is commonly associated with heart disease. However, not all chest pain is cardiac in origin. Non-cardiac chest pain, or NCCP, is a frequent complaint in clinical settings and can mimic the symptoms of angina. This type of pain may radiate to the neck, shoulder, jaw, or even the back, making diagnosis challenging. While gastroesophageal reflux is a well-known cause, musculoskeletal factors are increasingly recognized as significant contributors. Understanding the underlying anatomy and mechanisms is crucial for clinicians to distinguish between cardiac and non-cardiac causes, ensuring patients receive appropriate care and avoid unnecessary interventions. Non-cardiac chest pain is more common than many realize. Studies suggest that up to 70% of individuals presenting with chest pain in emergency departments may actually have NCCP. Globally, the prevalence ranges from 14% to 33%, and these cases account for more than half of all chest pain complaints. Although NCCP usually has a favorable prognosis, it can still lead to significant distress, repeated medical visits, and increased healthcare costs. Recognizing how widespread NCCP is helps highlight the importance of accurate diagnosis and the need for a broader understanding of its causes beyond the heart. Gastroesophageal reflux disease and esophageal motility disorders are the most common causes of NCCP. Musculoskeletal chest pain is often overlooked. Many patients with musculoskeletal-related chest pain remain undiagnosed or untreated, as their symptoms can closely resemble those of cardiac origin. Diagnosing musculoskeletal chest pain typically involves ruling out more serious visceral conditions. This underlines the importance of interdisciplinary approaches in both diagnosis and management, ensuring that patients receive comprehensive care tailored to their specific needs. Myofascial system is a continuous network of connective tissue that surrounds and links muscles throughout the body. Unlike the traditional view of muscles acting independently, recent research shows that muscles are intricately connected through fascia, forming a structural and functional continuum. This network allows for the transmission of force and movement across different body segments. The myofascial system plays a crucial role in coordinating movement and maintaining posture, and disruptions in this system can lead to pain and dysfunction in seemingly unrelated areas. Upper quadrant of the body includes the cervical and thoracic spine, the pectoral girdle, and the upper limbs. Deep fascia connects these regions, creating a myofascial continuum that links the head, neck, chest, and arms. For example, the brachial fascia of the arm connects with the fascia of the pectoral girdle and extends to the neck and head, while distally it continues into the forearm and hand. This anatomical arrangement explains how dysfunction in one area can lead to symptoms in another, highlighting the importance of viewing the body as an interconnected system. Myofascial connections between the head, neck, and chest are complex and vital for understanding pain patterns. The epicranial aponeurosis, or Galea poneurotica, forms a broad fibrous layer over the skull, connecting muscles at the front and back of the head. This structure continues into the deep cervical fascia, which envelops neck muscles and extends into the chest as the pectoral fascia. These layers create a seamless myofascial continuum, allowing forces and dysfunctions to be transmitted across regions. This anatomical insight helps explain why pain in the neck or head can sometimes present as chest pain. Myofascial continuum extends from the pectoral girdle through the arm and into the hand. The brachial fascia of the arm connects with the fascia of the shoulder muscles and continues down to the elbow, where it merges with the antebrachial fascia of the forearm. This fascia then extends into the hand, reinforced by the flexor and extensor retinacula at the wrist. Such continuity means that tension or dysfunction in the upper arm can influence the forearm and hand, and vice versa. Understanding these links is essential for diagnosing and treating pain that may appear distant from its actual source. Myofascial pain syndrome, MPS, is a common musculoskeletal condition characterized by pain originating from trigger points in muscles and their associated fasciae. Symptoms can include pain, muscle spasms, restricted movement, and increased sensitivity, often occurring in areas distant from the actual trigger point. For example, trigger points in the chest or neck muscles can cause pain that mimics cardiac symptoms. Diagnosing MPS can be challenging as the pain often appears in unexpected locations. Recognizing the role of the myofascial continuum in these pain patterns is key to effective treatment. Thorough understanding of the myofascial continuum is essential for clinicians evaluating patients with chest pain. Many cases of non-cardiac chest pain may be rooted in musculoskeletal dysfunction, particularly involving the myofascial system. By considering the interconnectedness of the head, neck, chest, and upper limbs, healthcare providers can improve diagnostic accuracy and tailor treatments more effectively. Approaches that address the myofascial continuum, such as targeted physical therapy or trigger point interventions, have shown promise in resolving symptoms that might otherwise be mistaken for cardiac issues. Ultimately, this anatomical insight can lead to better outcomes and more efficient care for patients experiencing chest pain.